Thank you so much for inviting me to present our work. So we're actually a very large shock center in New Jersey, but we are a DT center. We're not a transplant center. So it's given us some unique opportunities to try to recover our patients. So I'll be discussing that today. So I have no relevant disclosures. This audience knows shock has a high mortality. There's multiple etiologies of shock. We usually talk about acute MI shock, but there also is role for support in heart failure, myocarditis, post-cardiotomy, and other types of shock. And we all know that unloading can really change the outcomes of these patients. So as a result of all the great work that's been done in this room, our center modified a shock protocol to give to our acute teams so that patients can be captured at the right time, so hopefully before they get into that SCI, D, E, but more in the C set. And we follow this algorithm, and based on that, most of our patients with at least acute MI shock will come out with some kind of temporary MCS if they fit the criteria. As a result of this increasing use of temporary MCS, we do actually have a poster reviewing our vascular complications. We noticed that a lot of patients were with either prolonged use of CPs or were having inadequate management of shock. And so we actually came up with a PVAD escalation protocol, led by Dr. Anderson, Dr. Betsides, and myself. And this is something that we do where we created a PVAD team that's basically focused on management of the PVAD patient. And we look for these criteria to show either untreated, inadequately treated shock or shock that requires longer term support. And usually this consult is called within 6 hours of the either shock being identified or the CP being placed or boom pump or whatever acute device was used. And based on this algorithm, we then decide if a patient needs to be upgraded. So you see it's a relatively sick population of patients. Once our patient is optimized on their pump, so we've now taken them out of shock, we've gotten them off of their pressors, hopefully, maybe there's some low-dose inotropes on board, we now start looking at our exit strategy. Are we looking at this patient being a bridge to advanced therapies? For us to have a heart transplant, we have to call another center and have them now take on a high-risk patient. So we usually are trying to do something that we can manage at our center first. So our goal is always to try to recover the patient if possible. If not possible, then we are looking at either LVAD or possible inotropes. So when we look at these patient population, we see that once our hemodynamics are adequate, we're off of inopressors or at least on low dose of inotropes only, is there a role for a GDMT introduction? And it's a very controversial thing, a shock patient with a GDMT. We do remember from our medical, when we were doing a lot more medical heart failure, medical shock, we were using vasodilators in these patients. So as we do use our inopressors, we have our increased contractility with our pump, right? Our pump is giving our cardiac output. So at this point, is there a role for neurohormonal modulation and introduction of low dose of drugs to prepare this ventricle for possible weaning? And so what we try to do is introduce, based on the appropriate clinical scenario, the right drugs. Most of our patients are getting aldosterone antagonists the day that the pressors are stopped. Just because unless there's a potassium or a creatinine issue, most of these patients are being aggressively diuresed anyway. They're getting tons of IV potassium, so why not give them? The one worry that we have is the high potassium, so why not give them the drug that helps with that? The other drugs kind of come in as appropriate. So, we know that our patients have a higher rate of PVCs, VT, AFib, if there is a role for a beta blocker. And this is actually a very controversial topic. If the patient is out of shock and tolerates a small dose of a short-acting beta blocker, then beta blockers can be optimized in this patient population, and we go down this algorithm. In conjunction, we're also, especially if we're off of inotropes, trying to introduce that vasodilator to replace that unloading that's coming with our Impella device. We will then add some vasodilators, hydralazine, nitrates, ACE inhibitors, ARNIs, ARBs, whatever is appropriate for your patient based on the clinical scenario. Also looking at their insurance and what they're going to be able to go home on so that you're not constantly changing medications during the course of their care. And then, if able, SGLT2 inhibitors. This is all usually, specifically the beta blockers, but most of the baseline drugs are usually started with a SWAN in place. We try to keep our SWAN in 5 to 7 days if we know that this is a patient that we're looking at weaning. Otherwise, we are, if we think that this patient's going to be a bad, we'll give them a SWAN holiday earlier on once they're compensated. So the discussion has been about a lot of recovery, but the question is, when we're talking about LV recovery, we're looking at really high EF. But is it truly that we're looking for recovery or remission? And with our cardiomyopathy population, I don't know if by the time we're getting them and we're supporting them, I don't know if recovery is possible. AMI population, there may still be some reversible damage that we are now protecting with this device, revascularization and GDMT. So one of the things to discuss is, could we be looking for a lower EF goal with remission rather than full recovery? And you'll see with our data that that's kind of what we're aiming. So, we all know heart failure guidelines. How do we take care of our patients? These drugs, going down this algorithm. Many of the AMI shock patients are first-time heart failure patients. So they they're before they even have their ICD. So we're really looking at optimizing meds so we can, at that 3-month mark, not have to give them an ICD if possible. And looking at the work that you've all done with, Mody and I were talking about this before, the LVAD population. This is the population that we actually saw that there was possibility for LV recovery with proper unloading and with long-term proper unloading and GDMT in conjunction. And so, kind of following this, can we fast track this and bring this into that 14 to 15-day timeline? And in select patients, it's maybe possible. So I was looking through the literature to see, what has actually been done, because, I remember I was a fellow when you first stopped beta blockers in shock, then you kept beta blockers at half dose, then you maybe stopped beta blockers, and it's been all over the place. So there actually has been some look at inotropes in patients with cardiogenic shock, using beta blockers, either antecedent beta blockers or concomitant use of beta blockers, and there actually hasn't been any shown increase in mortality in these populations to show that this is not actually detrimental, but is it beneficial is the question. There also has been, a lot of work. We all know when a patient comes in with an anterior LMI, you want to get them on their beta blocker and their ARB as soon as they're revascularized. So now is it different with a patient with a pump? And so again, another question, you've taken them out of shock. Are they now similar to the patient that just came in without the shock? So our experience is 152 patients. This data is a little bit different than my poster because this is all comers, including the ones with cardiac arrest. So we had 115 patients without cardiac arrest and 37 patients with cardiac arrest that came to our center. Predominantly male, mean age of 63. AMI accounted for 81 of these patients. And of the AMI patients, 60 patients were revascularized with primary PCI. We also have a mixed group of patients that also may have had either post-cardiotomy shock or had high-risk pre-CABG device placed, and that's included in this population of 15. We have acute decompensated heart failure in 49 of these patients, and 34 were purposely put in as a bridge to advanced therapies. So looking at this is a very similar population to most of the other heart failure populations that we look at. But to see, the interesting thing is that our explants EFs are really not that high. And in the ACS population, we only have a 4% improvement in EF. But this is also now talking about 11 days after the insult. So, to ask the LV to recover to it's not, we usually will see that LV recovery, as we all know, a few months later. So, but we are showing, but these patients are compensated and able to be explanted. The other thing that's interesting to note is that the acute decompensated heart failure patients have the longest mean duration of support, which kind of fits the patient population because we really didn't do anything to help them other than unload them. So there still is another strategy that has to then get them out of their decompensating state. So of this group of patients, we have 74 patients that actually had native heart recovery or remission with an EF range anywhere between 20 to 55. And remember, this population is mixed between patients who were acute MI shock, pre-procedural, going into shock, and post-cardiotomy shock. 64 patients actually were discharged on GDMT alone, so just pills, no inotropes. 10, unfortunately, did need some inotropes, but were also concomitantly managed with drugs. Of the 64 that were recovered to GDMT, we had 42 of these patients that were acute ACS. So it makes sense that the patient had an MI, which was probably their index heart failure or admission. We revascularized them. They are now out of shock and on their road to recovery. I think it helped that they were early unloaded, so that whole cascade that would have resulted in possibly needing advanced therapies was aborted. 51 of these patients did undergo some form of revascularization. 30 were post-PCI and 21 were post-CABG. And at the time of discharge, 31 patients were at least on 3 pillars of GDMT. So, I mean, that's a pretty reasonable number of patients. This is starting in 2019. We didn't get SGLT2 inhibitors on formulary until last year, so there is a little bit of a bias that SGLT2 inhibitor usage is low in this population in the prior group, but the current practice is that they're usually leaving with SGLT2 inhibitors unless some contraindication. 18 were at least on 2 pillars, and 14 were on 1 pillar. And just to note, of the recovered patients, that's 74, 2 patients needed to move on to advanced therapies. 1 had an LVAD, 1 had a transplant, and 2 had expired due to sepsis at subsequent admissions within the year. So this is the breakdown of the drugs that we use and the percentage of patients. So it's really funny that we start off by talking about beta blockers. Why are we using beta blockers in shock patients? But we also, as heart failure doctors, are very good at discharging our patients on beta blockers. So we do have a 97% compliance with beta blockers at time of discharge. We do sometimes in the patients who are very tenuous with their blood pressure and we want to use other pillars, to use metoprolol tartrate, but that's not a common practice. Most of the time, our patients are on metoprolol, succinate, bisoprolol, or carvedilol. We do use ACE and ACE inhibitors and ARBs depending on the patient's ability to afford or tolerance, and this is around a 45% compliance. The other patient, we do have 6 additional patients with all other drugs. We're not a very big ARNI center in this acute group. We do try to get them on ARNI as outpatient as quickly as we can. But not in the acute admission, though I've become a little bit more courageous and I've been trying to do that more frequently if I can, especially if they've been on it before in the heart failure population. And the aldosterone antagonists are usually the only reason they would not be on one is because of hyperkalemia or renal dysfunction. As I told you, SGLT2 inhibitors did come into our algorithm later in the game, but the last 15 patients, 12 of them actually did go home on them. So in conclusion, early MCS in conjunction with management of shock can result in improved outcomes. Once a patient is compensated on MCS, leading to GDMT should be considered to enhance native heart recovery. Patients with ACS have a higher chance of coming off of medication, suggesting more recovery, whereas patients with non-AMI shock, we should maybe be considering remission rather than recovery as our goal, and maybe longer term support with either a durable LVAD or hopefully eventually when BTR does make its way into the market, something like that could maybe help us with this bridge to GDMT. And thank you to my team. I have a great surgical team, which really allows us to do a lot of this up front, unlike some of the struggles of some of my colleagues. And we have a really great interventional team as well. So thank you all.